Oh, well, thank you very much for joining us. Just to quickly welcome everyone and just to thank Julia Ambler from KZN, who is going to be our co-facilitator for today. Prof. Liz Gwither was going to join us, but unfortunately had to decline this afternoon due to a family emergency. So we wished her well, and Julia and I will be taking good care of you. And Julia is going to be discussing communication specifically around COVID and the importance of shared decision-making with your patient, which I think is obviously very, very important and will raise a lot of interesting discussions. We will also have Judy Ziegel, who will be joining us as our psychologist a little bit later on. And then I'll also be sharing just a little note, a very interesting article just around shared decision-making if you'd like to read in your own time. I've just shared that on the chat. And if there are any questions, we've received a lovely question from Janet as well as from Dr. Goba. We'll crack into those after Julia's taken us through a few slides just to preempt the conversation. So a nice group this afternoon, so lots of open conversation. So feel free to post as we go and we'll be able to answer those for you. Julia, it's now 3 minutes past, and if you want to quickly set up while we're chatting, and then we can get cracking.
Let's go. Can you see me?
No, I think, yeah, there we go. You can start again.
Is it coming up? Can you see big PALPRAC?
Yes, we can indeed. Very nice branding, nicely designed.
Thank you. Thank you. I received it from a friend.
You know the right people.
So good afternoon, everyone. The reason for picking this particular topic was largely based on the article that Margie put onto our PALPRAC group. Some of you may have seen it. It was a New England Journal. And it really is quite a nice narrative around a particular patient and everyone's different perspective and how they came to make decisions around this particular patient in the time of COVID. And a lot of the article was around goal setting. So I thought I'd bring up the topic of shared decision making because in my experience in South Africa, it's not a commonly used term and it's often very much misunderstood. And I think when I teach about it for the Medical Protection Society, a lot of people think it's how we as clinicians make decisions for our patients with other clinicians rather than the actual conversation that happens with the patient. So I'd like to just quickly focus on that, bearing that article in mind that you can go and have a read. I'm sure some of you will have already seen it. Just try and focus us on the important things that are happening during COVID with our patients and how we can enhance our relationship through the way that we're practicing and making decisions that are so complicated. There you go. So now you really know what we're talking about. Sorry. Okay, so firstly, just to define what we refer to as shared decision making. So it's really a philosophy and it's a process. And it's all about the patient and the doctor and often the patient's family, and particularly in COVID, I think the family should be very much involved, and that they can work together in a partnership to make a really good medical decision about their care that is going to benefit the patient mostly, and that aligns with their preferences, their values, and patient autonomy, but also aligns with what we know is clinically correct and good. So it's got to be based on science and evidence from a medical perspective, taking into account the patient's values and preferences. And really, if we look at what's happening in the courts of law around the world at the moment, is patient autonomy is the most important thing. We used to say that if other reasonable physicians would do the same thing, then that's, you know, what is reasonable, and the court would decide in your favor or against you based on that. But more and more what we're seeing is that autonomy is the key factor for patients. And if we have managed their autonomy correctly, and if they are truly autonomous and we've allowed them to be truly autonomous, we protect ourselves medico-legally, because it's now what a reasonable patient should be able to accept, not what a reasonable physician would do. And that's been quite a fundamental change over the years in the courts. Around medico-legal issues. And what we're talking about here is real communication. It's not information sharing. And this is something we talk about with the junior doctors a lot. When we get taught this at medical school and what we get used to doing, is kind of breaking bad news, but just sort of issuing instructions or telling the patient what we found, what we think, without actually really getting involved in the conversation. And I think this group here, the fact that you're here, are probably the converted already that understand what real communication is. So there are three main steps to shared decision making, and the first is really to gather information. This is understanding who you're dealing with. You cannot advise a patient properly in a holistic manner if you have no idea about them. You cannot say that everybody needs the same operation or the same treatment. You might know that for this particular infection, they need that antibiotic, yes, but in terms of where their treatment should be, how it should be, what the side effects are, there's a bigger picture at play, and you need to understand our patients to be able to really help them make good decisions. So first to take into account is the active versus the passive patient. Now, the active patient is the kind of, what I have in mind, the stereotypical business person who doesn't have time to be sick, who comes in and demands an antibiotic for their viral infection because they want to nip this cold in the bud. They can be extremely great because they know what they want, and it can be easy to manage them because you can have a conversation and they're empowered. But at the same time, if we don't really do a detailed shared decision with them and we let them kind of bully or run the process of the decision making, when things go wrong, they can come back to us and say, but doctor, you knew, you were the doctor, you should have told me. On the other hand, there's our very passive patient, and for me and KZN, these are the elderly, gorgors, possibly rural, less educated, and this is just a generalization and stereotype. And they're not empowered to ask questions and to demand answers. They kind of just take what you say. But these patients can be very dangerous when they weren't involved in the decision making because you treated them paternalistically as if you're the parent and they're the child. And then when things go wrong, there can be huge levels of anger, and there's always going to be a family member who's a nurse or a doctor that comes back to fight the fight. So regardless of the type of patient you've got, we have to try and engage with them into a shared decision-making process. So the gathering of information, we need to know what they think, what they're worried about, what they're expecting. Okay, expectation is the root of all disappointment. A ridiculous story that highlights this for me was when I first got married. I'm divorced now, I'll just put that out there. And when I first got married, I had lost a lot of weight for the wedding, was looking very svelte in my wedding dress, and then got to England to work and put on a lot of weight very quickly, and was now doing all my own housework as well, and a newly married woman and working night shift as a doctor. And one day the iron exploded and I was just burst into tears because I had no thin clothes left. I mean, fat clothes left. I only had thin clothes. I had nothing to wear. And later in the day, my husband phoned me and he said, oh, I've got a surprise for you. And I was so excited. And sure enough, I get home and he presents me with the state-of-the-art iron. I cried again. I really thought he was going to give me a nice dinner. Why? When I had already put on weight, that I think he was going to take me out for a meal. I have no idea. But the point is, I was so disappointed. And our patients are also like that. They come in with an expectation. And if you don't understand what the expectation is, you're not going to manage them well. You're going to miss the boat. And a disappointed patient, it becomes an aggressive, potentially very angry and upset patient. So understanding your patient before you advise them, then finding out what they know already, and include Dr. Google, especially now with COVID. Everyone is on Google, on News 24 is watching the statistics. Everyone knows something, and of course there's an expert in every family. So find out what they know, what they're worried about, what their major issues are and their concerns. Then of course what's most important to the patient. So this, if you don't understand, what matters to them, so maybe being at home and spending time with family is more important than living longer and being ventilated in hospital. So that comes to advanced care planning as well, but it really is the fundamentals of what is important to the patient, and always using empathy. Then once you know who's sitting in front of you, then you can help to make them understand what they need to know. Now, for me, this is a very interesting phrase. It is not your job to make people feel better. And I'm just going to say it again. It is not your job to make your patient feel better. And I think for a lot of us in medicine, that's quite hard because we thought that's what we were going to do. You know, think about all of us, social workers, psychologists, the whole point is to surely make people feel better. But at the same time, it isn't really. A lot of it is about actually helping patients face whatever they've got to face and help them feel safe while that's happening. So it's about being someone that they can trust and telling them the whole truth and nothing but the truth and helping them to face that. They're not going to necessarily feel better, but they will cope better if they understand the whole truth. So then we have a legal and an ethical obligation to tell the truth about their options. And that's all their options. That's doing something, doing nothing. Of course, we could always do nothing. And I think if you're a hospital doctor or a clinical practitioner that is prescribing or running interventions, always ask yourself, have you offered that as an option? Have you offered them? Of course, we could always do nothing, but there are risks and benefits to that as well. So discussing all the options, the benefits, the risks, and the costs. And this is hugely important because the costs, just hang on a second, there's my son. You're now on a webinar. You can go close the door, thanks. Sorry, guys. They've just come back from having their haircut, so they're all very smart. They're going to school tomorrow. Sorry about that. So I just want to come back to costs. So any of you who are working in private, one of the really important things is that it is absolutely in the law, in our health legislation, that we must disclose what things are going to cost. And not only now, but future admissions that might be related to what we're doing. So just to always bear that in mind, that cost is very important in the private sector. And then once you've got, you know your patient's clinical condition, you know everything about them, you've now discussed all the options. Now you can say, well, based on what you've told me, based on what I understand about you as a person, your job, what's important to you, what you're scared of, this is what I think we should do. And you absolutely have to make a recommendation. The third part of the decision making is to make the decision. And all the research around this shows that it doesn't matter who makes the decisions. Often actually patients don't remember. Was it the doctor who made it? Was it me that made it? Was it my wife? What is important is the process of the decision making process, and then coming back to check their understanding. This isn't something South Africans really struggle with. Actually, I think everyone around the world. I'm excluding our social workers and psychologists and social workers on the group. I suspect you're a tad better at this than we are. But most doctors that I come across really feel awkward to check someone's understanding. So the norm is, any questions? And the average patient will go, no questions. So the only way to know whether the patient and the family or whoever you're with understand what you've actually said to them is to find a nice way, we call it the collaborative tellback, a nice way to tell us what they've understood. So it might be, I know your wife's waiting at home and you're going to phone her from the bed now. What are you going to tell her about our discussion? And that will give you a very clear idea of what they've remembered about what you've said and what they're going to include. And if there are any misunderstandings or mistakes, you haven't explained yourself well enough, you get an opportunity to do it again before that poor understanding is entrenched. And this, I think this is hugely important. Medico-legally, it protects you if patients remember what you've said. And also just, you know, patients only remember about 30% of what we tell them. So if we do this collaborative tellback, we can improve that up to 8 times in the literature, it says. So really finding out what they understand. And now we're dealing with crazy circumstances where people are confused and overwhelmed, and us as clinicians are confused and overwhelmed. So if we are making decisions with our patients, getting them to repeat that back to us before they communicate to their loved ones or before they go home, if that's what they're going to do, is hugely important. And then obviously the last part is documenting your decision making. There's a lot of confusion around how we document decision making. Do I have to write everything down? What is too much? What is too little? The bottom line is that no one can say to you, this is what you must include. The key is to make it very clear to anyone reading the note after you that this discussion took place. So if a decision was made, and say the patient has decided not to be treated in hospital for COVID, but would rather go home for home care and palliative care and possibly even oxygen at home, why did they make that decision? How did the discussion go? And literally document a few things that personalize the whole thing so that anyone reading it, including a lawyer, can say, oh, this conversation definitely took place. Look, my wife was worried about X, I'm worried about this. The patient mentioned that. So it's not having reams and reams of notes. It's about making what you write down count so that everyone who's reading it understands why the decision was made and the kind of discussion that took place. So I hope that helps a little. And then just thinking about the implications in COVID particularly, what we know from all the literature, and not specifically COVID, but from years and years, since 94 really, when the first papers started coming out about litigation and who's sues and who doesn't get sued, we know that patients and families don't tend to sue doctors that they trust. And the MPS webinar around withholding and withdrawing left us all a bit unsure, actually, because we're not protected. If we withdraw a ventilator or life-sustaining treatment in a patient that might have had a good prognosis, we are not protected currently by any document or legal framework. There just isn't one. So all we can do in that instance is what will protect us is impeccable communication skills. So dragging out everything you ever learned about how to communicate, using the tools that are online. There's some wonderful resources on the PALPRAC site. Vital Talks is one of them. If the patient and the family perceive that every attempt was made to be open and honest, so if no one ever phones the family from the hospital, knowing that they can't visit, knowing that they're not allowed, that creates such anger and frustration that if things go wrong and the patient dies, you can just see where that's headed. So if the family and the patient feel that actually the doctors have tried, they've video called me, they've WhatsApped me, they've phoned from the ward, I've had information, it makes a massive difference to anger levels and acceptance levels later. Then following national guidelines, and although guidelines are not law, they are somewhat protective if you are following what other people, the experts in the area, are suggesting. And there's some really good critical care guidelines out, and PALPRAC has obviously got our palliative care guideline out. Coming to one of the questions later is about communication within the team. Working in a team is so important. To be on your own is a bad idea. So if you're alone as a GP, freestanding specialist who's not in any kind of team structure, those are the people who are going to be more at risk for issues. You need that support of your colleagues, not only medical legally, but just emotionally, actually, because some of these decisions we're going to be making for patients in the next few months are really difficult, and those in the Western Cape and Gauteng know already. And then lastly, impeccable documentation. So that was all I had in my presentation. Then there are the two questions that Andrew referred to earlier. So I hope that raises some kind of issues not issues, but ideas for people to discuss. Can I hand back to you, Andrew?
Yes, absolutely. Well, thank you very, very much. I mean, for someone who comes from a corporate environment and doesn't have much medical experience other than my week in ICU and making friends with lots of wonderful nurses and doctors, I speak from low experience. But the one thing I have taken away, and before we get to the questions, I actually wanted to mention, and through your reference to it, actually pointed out, Jane Cunningham always talks about, specifically in the context of COVID, that the one thing that is so important in palliative care is the small things. And those are patient-specific things. And I think that also speaks to the communication skills and the understanding, and I suppose also that resilience to respond and recollect exactly what the conversation has, and brings to your point. But as a GP who specializes in peds, I'm quite keen to know how you have this conversation with children.
Yeah, it's really difficult, and it always comes down to, depends on the age and the stage of development of the child, and that in itself. So for me, it's quite easy to do that whole patient aspect thing, because I have to to ascertain the level of ability of the child to understand what we're talking about. And I have to spend that time getting to know them and getting to understand what they're really worried about and what they're really scared about and what they think is happening to them. And it's actually fascinating. I worked with a palliative care doctor, GP, in the UK, and when I was a brand new palliative care doctor, I was terrified, and we were going to see a patient in the early days, and she was a little girl. She was about 9, and she had a brain tumor, and she was staying in the hospice for some respite, and she looked very down. So he said, "Come, let's go talk to her." And I'm like, "Oh, I don't want to talk to a 9-year-old about her disease." But anyway, he says to her, "What's wrong with you? You seem so sad." And she said, "No, I'm not sad." Okay, well, what are you then? Are you angry? And no, I'm not angry. Well, what are you? Definitely something. You're not your normal self. And eventually he said to her, "Are you scared?" And she was very quiet for a bit. And after a bit more discussion, she said, "Yes, I am scared. I'm scared of dying." And well, I was freaked out by this. I'm ready to leave the room or say, "Oh no, sweetie, don't worry. Everything's going to be fine," knowing that actually it's not going to be fine at all. And he said, "Well, what about dying scares you?" And, well, I was nearly finished by now, you can imagine. And she turns around and she says, you know when you die, they bury you in a coffin, and then the worms come and eat you." And I'm really scared of worms. And I was like, well, that's it. And that is what working with kids is like. So, she wasn't scared of dying at all. She was scared of worms. And when we spoke about worm-proof coffins and our options, she was a different child, and she skipped out of there happy as anything. So for me, that is what it's about, is finding out who they are, what they're worried about, and actually meeting that need. In terms of the decision-making itself, we've got consent laws and stuff in South Africa that guide us. But I tend to err on the younger side because we're used to having those conversations. But you've also got to get the parents' buy-in. A lot of parents want to protect their kids from the truth. We spend a lot of time working with that.
Sure. It sounds like an incredibly complex field. Probably deserves a whole hour for itself to talk through. Judy, welcome. I see you've also joined us. Sorry, we started without you. I did make the introductions to everyone joining us this afternoon. I see your hands up. Would you like to weigh in on the conversation? Oh, okay. I think you're still on mute.
Okay, can you hear me? It's not meant to be up. Sorry, I'm on my cell phone.
It's quite all right. Well, welcome to the meeting nonetheless. I did see Janet had joined us. There was a question here around creating a supportive network between public, private, and NPOs. Janet, would you like to elaborate on your question a little bit?
I just have to do this.
No,
Thank you, Andrew.
Right.
I think just working and trying to set up support things locally has raised that, because everybody's in a slight panic. But what really brought it home to me was the Zoom the other night of put on by the Medical Research Council, where the people in the Western Cape were talking in order to give other people heads ups about how things were for them. And there was one really distressing exchange where a doctor at Pinelands, who's a physician, had described how things were at Vincent Pallotti, and then a physician from Tygerberg spoke about the fact that it's a waste of time to collaborate with the private sector. They're not interested, they don't care, they're not going to help us, so just leave them off the list. And this doctor from Vincent Pallotti had just been recovering from COVID, and she was fragile, and she said that the private physicians there had all agreed that they wanted to support the public sector, but Discovery was the intermediary between the two, and they hadn't got a document signed yet. So it was so distressing to see that kind of animosity developing, and it was very unnecessary. And subsequently, there have been quite a lot of things in the paper about how the public and private sector collaborations could work. And pointing out a very real fact, which is that public servants carry on getting paid when they're working from home or doing telemedicine, and doctors in the private sector have mostly really suffered huge income losses. So it was just thinking about that and thinking about how hospices can be involved in that sort of triangle of care. And locally, we've been trying to figure out how we can help the COVID ward by going to patients' houses with a smartphone and facilitating the communication between inpatients and their families if they don't have data and if they don't have a smartphone, and sort of linking them with spiritual care and things like that. So I just wanted to put it out there that it's an area where I think, well, my big disappointment is that the 1994 ANC Health Plan was never implemented. And if it had been, I think all these ugly feelings between different health service delivery philosophies and systems wouldn't exist. But we're in a very polarized setting, and that's really scary when we need to pull together as much as we do now. And it's illustrated by small things like Shelley reporting there's no metoclopramide in Cape Town. There's plenty of metoclopramide in the public sector and none in the private sector. So, you know, there are all these things that are going on that worry me enormously. And I think that clever people within our group of palliative doctors can maybe bring some ideas to how to create better teams.
I think what's interesting about that is you talk about the triangle of care, and I think within that it's when one point of that three-way relationship starts requiring more assistance, they should be able to draw on the other two, and there should be that openness to communication. So it almost feels more like a miscommunication rather, you know, under the stress that they're under, rather than, you know, unwillingness to help. Because I'm yet to meet someone within just our PalliCOVID conversation who doesn't send through a message saying, listen, I'm here, there, but it's nothing I can do, but I'd like to help. You know, so I think there is a willingness. It's just to overcome those obstacles. Julia or Judy, I don't know if you'd like to weigh in on this. I think a very, very interesting topic that Janet has raised.
Julia?
I was waiting for you, Judy. I wondered, I think we've got a couple of people from KZN here. Lashista, I think aren't you at St. Augustine's? Have you had any contact with the state health system? I mean, for me, I think that, you know, it is an absolute drama, and I can see it unfolding in KZN right now, that there's this animosity growing. And even between married couples who one is in the state and one is in private, and now the one income is gone, and, you know, who's seeing which patients, and are you bringing COVID home? And instead of working together, we're now accusing people of, when they become positive, did you not wash your hands? Did you not? It's kind of, I think there's a psychology behind the whole pandemic that's making people crazy, well beyond our usual animosity between private and public. So as far as I'm aware, there isn't a lot of collaboration in KZN. I don't know if anyone else is aware.
No, Janet mentioned a supportive network is necessary to be built. Is there any one organization or any group of people that are possibly making an effort to get this up and running that anyone knows about in KZN anyway?
No, certainly not that I know of. I mean, what I took away from our chat last week around how to boost morale, I think what they were saying at Helderberg and at George Hospital, I actually took it on myself to email the head of Albert Lutuli Hospital, not thinking I would ever get a response, or that they would take my advice, and they have. It's, you know, they're not entirely, they gave me a full report of what they've already been doing, which they didn't need to do. They didn't need to, I'm a nobody, I'm an honorary person in their system. And then they've started to send out a weekly newsletter around the number of staff cases, which was one of the suggestions I think that came from George, and to talk about the recoveries. So for me, that was the one thing I've done, to reach out to the hospital and say, look, we want to help wherever we can. These are some suggestions. What else do you need from us? But other than that, I don't.
I suppose it's about the professionals, that are aware of the need, actually being proactive and linking up with themselves and making moves like you did, and that spreads.
I think Linda's got her hand up.
No, she was just giving you a round of applause.
Oh. I'm not good with all these hand signals.
It's quite all right. That's why I'm here. But I know Margie Munings was the one who brought up the communication around from the hospital management, which worked so well. And I think that's a prime example. Keeping those communication channels open. It's never really a two-way communication, but I think that openness to extend that communication also through is just a reciprocal thing, where it's also like we also want to get feedback. We want to know what you're thinking, what you're feeling, because I think it is very, very important. And I think through that process, you'll also be able to create a relationship where people, hopefully within the private and public sector, are able to offer their services and help where need be. I mean, I know, and perhaps someone can also weigh in. I know that there are a lot of regions. I don't know if there's anyone from the Eastern Cape. We've obviously seen a few reports coming through that they're under increasing pressure. Is there ways that we can also facilitate, even if it is just conversations to assist around communication, having those difficult conversation, advanced care plans? I think they're all relevant topics that, within our network, we can certainly, also help. And that's a prime example. I don't know if Dr. Goba is in the room with us. There was a question. I see a smile there. Hello, how are you?
Hi,
Thank you for
I'm
joining
all right.
us.
How's everyone? Thanks for
Judging by
welcoming
the
me.
smiles, I think everyone's good. The Western Cape, we're glad for the warm weather for now. You had a lovely question around poor planning and communication resulting in disorganized and frustrating service delivery. I'm so glad you're here. I'd love you to just pose the question to the group, and hopefully Julia and Judy can answer, and I encourage everyone else to also weigh in on that. So go ahead, the platform is yours.
All right, thanks, Andrew. I think one, maybe just to comment on the previous discussion, I am aware of a group that has been formed between our Department of Family Medicine and Internal Medicine, which is mostly run between the university and the Department of Health KZN. So maybe, Julia, we can contact, I think, the head of internal medicine or the head of family medicine, because I see in our webinars, they're also looking at the support structure, but it's not yet formalized. So in the KZN region, that's one of the things that I'm aware that is going on.
Fantastic.
And then with regard to my question, I think I sent the question before I saw today's discussion. I just joined the group today because our head of department actually shared the link a few days ago. And unfortunately, on leave these few days, I'm able to catch up on my reading. But I think for me, what raised that
Titi.
Oh, I think we've lost Tutu there.
Mostly the time to actually discuss the patient's.
Oh dear, it's not a good.
Not a good line.
No.
Tutu, I don't know if you want to maybe try and reconnect. Sorry, Tutu, we lost you there. If you could maybe just start again.
Oh, okay. All right.
Sorry
Can you hear me
about
now?
Yes.
All right. So I got called to the isolation ward when one of our patients had actually passed on, a 82-year-old male who was at Northville Hospital from one of the local old age homes. I got called because firstly, the MO had already done the death certificate and everything. And then they phoned the family member who was in the UK. And she was absolutely distressed and angry with the hospital that no one had phoned her while her father was sick. How come they're phoning her now to say the father has passed on? So I went to review the records because I'm the senior registrar and I was on call on that day. So I went to review the records to see how I could actually deal with that situation. When I reviewed the records, I realized there were no emergency contact numbers on the file on admission. it just said the patient came from this particular home, and there was not even a contact number from the actual home that the patient had been in. And so when I phoned the daughter says she wasn't even informed that the parent had come to the hospital in the first place. And for the past 3 months, they've not been able to communicate with the old age home where the father was. So now you're picking at the end of the stick, and you have to actually deal with the challenge at the end. So what I did is then I phoned the old age home just to try and get the details of who was in charge. It turned out in this particular case, family members had disagreed about whether to put their father in the old age home or not. So the one who was in KZN had arranged for the old age home, while the one who was in the UK was not aware. So it was fortunate that it was resolved by picking up that it was your sister who made the arrangements and your sister was informed. But we often find ourselves in the middle of those, and it's quite difficult. How do you then address a challenge like that from a palliative perspective? Because I guess they might have communicated with the person who sent the parent in, but the one who was not involved in the care plan or for the past 3 months had not been involved, suddenly comes into the picture. And we see that a lot in the public sector.
And I don't know. Do you think you need to work more with the home and educate them about the importance of keeping in touch with the family and giving them all that information?
I don't know. I guess I'm looking for guidance, because for me, this highlighted one of our experiences. Normally, you find 2 sides of the family or 3 or 4 sides of the family coming in, and then we've spoken to one side of the family, the one who came in, and you're not aware of what is going on if the person has got like 2 or 3 children.
Yeah. It's not easy because that's not medical, but it's hugely linked to palliative care because it's all the psychosocial aspects.
Yeah. Linda, I see your hands going up, and you've also made a comment there. You'd like to weigh in?
Yeah, I just wanted to say, I think one of the saddest things for me is the lack of social work services in the public sector hospitals. There might be a social worker that serves 4 or 5 wards, and and there is virtually just dealing with the traditional kospakkies and komberse stuff, like in the old days, and a lot of the time social work is so stigmatized because of that. But the real discharge planning, assisting and assessing, just what you've mentioned in the intake interview of the social worker, looking at the complexities of the patient in the hospital, to be able to do that assessment proactively and then, reach out to family proactively would be the ideal situation. But you can't do it if a social worker is working 1 to 10 wards. And the fact is that in all the policies being developed, there is no human resource or budget attached. So the inefficacy of everything is a huge problem, and we are going to have this for years yet. So we need serious advocacy about the funding of services and the HR component, and we need to look at how we address that. Certainly from I serve on the Ministerial Task Team for Cancer, and I'm constantly talking about that. But we need more than talk. We need real social action. The days of talking are past. We really need to get back to the basics of social action, never mind palliative care, to get what we want. But Willie is doing some great work with networking. You must ask her about that, Andrew.
No, absolutely. Well, I was actually going to respond to your comment there, because I think that's also something that we can share with our network, and it's an important point to raise. Janet, also thank you for your comment. I've just shared the link to our palliative care for COVID-19, and on there is to do a huge amount of resources available. And you're also more than welcome to contact me. I'll just pop you our email address. Willie,
translated them into Zulu. Just can I say, for the KZN people, they're busy being translated into Zulu as well. So that'll be on the website soon.
Okay, thank you very much.
I won't put my camera on because there's not a good connection. I already went off a few times.
That's quite all right. Thank you, Willie.
I think I've been telling in this group that we put teams together of palliative counselors psychologists and social workers. And in KZN, we have a group of 14 now in the Western Cape. There's quite a big team in Gauteng. They already got referrals now. But I'm looking at the other provinces, Mpumalanga, Limpopo, because that's where the resources are often less in the psychosocial resources than in other provinces. So if you have any contacts for me, please pass them on. I'll put my email address on the chat. And what we're now looking at in where the active teams are is how best can we link with referring doctors. Like in the Western Cape, there's a few big hospitals like Grooterschuur, Tygerberg, who say we actually are sorted with our psychosocial support, which is actually great, because palliative care has been there for a long time. There's good teams in place. They're roped in their psychology, their psychiatry departments, but at the same time, they know about us. And if they would be at dire straits, they know who to turn to. So we have a contact person in every team for every province who then will take the referrals and pass them on to the team. And whoever is available will then contact the family, will contact the medical team, but probably walk into all those obstacles that you've just been mentioning, especially because these teams are not there because of palliative care. They're there because of COVID-19, which is chaos in a sense, because it's something that you can hardly prepare for. Yeah. Julia.
Can I just, well, thank you, Veli. One of the, so I've got two comments. One, just to respond to Veli. I mean, I get so excited about additional resources for our hospitals, but if I think about a place like Albert Lutuli, and I put my head on the block every time I mention the name and talk about the fact that I work there, and they don't pay me, so I should be much nicer than I am about it. But I think one of the issues we've had with psychosocial services, when we've said, let us as an NGO bring in our social worker, that's the last thing they want, because it takes away from their statistics. So at the moment, if they can prove that they can't do their job because they're overwhelmed, they might get a bit more budget at some point. We come in and mess with their statistics, and then it looks like they don't need any extra budget. So that's one of the very sad realities we've had to face. But I'm hoping with the chaos of COVID, maybe we can get a wedge in the door there and say, actually, it's time for extra help, because those poor social workers are not managing. Even before COVID, they weren't managing. Yeah. And then to come back to Tutu's point about the family, one of the things we teach, I mean, obviously in palliative care, you've got more time and it's lovely, but even as any kind of intake doctor, there isn't a social worker who can take your social history, and the social history is relevant to the medical care of the patient. And we see it all the time in peds, because the poor father, no one even asked if he was around, let alone alive, let alone involved, let alone missing his child that's admitted with whatever disease. And then he comes in at the end saying, very angry that we started this treatment or that treatment without his permission. But the mother didn't feel empowered enough to say, well, actually, doctors, you have to call in the child's father as well. He'll want to know. There's none of that. But if up front the doctor doing the intake said, who are the important decision makers, who's in the family, is the father around, just a very basic social history, we would get a better idea, like which kids are important. I know your case from the children, from the home might be different, because maybe their contact details weren't up to date, and maybe this old man couldn't give you enough history, I don't know. But for me, it's just such a frustrating thing that we don't ask. It's like the social history is no longer part of the medical importance in a case, which is just not true.
Yeah.
Well, what is interesting, Julia, about that is that we as family physicians sometimes try and incorporate that into our emergency consults. But the patients actually get irritated when you ask them things that have got nothing to do with their current complaint. So if a patient says, I've got chest pain, and they want you to tell them whether they're having a heart attack or not, while you're trying to calm them down and trying to take their genogram, they're like, no, that's not important. Why are you asking me that? So,
Oh dear. Oh gosh.
But just through Jana's comment, I actually just went and reviewed the Meet My Loved One document again, and I just think, you know, the questions asked there are, they're so meaningful, and I think they spark so many other discussions and points for families when they're under stress and they're in that situation that they're admitting someone. You know, when people respond very differently to these sorts of triggers, and I think what's interesting is what they forget to tell you that is so important to the conversation. I think this document, although it's very basic, does lend itself to prompting a lot of those things. I see Dr. Mohammed has joined us. Hello, Shireen.
Hi. I've been, I wanted to go to an earlier point that Dr. Goba had made about that family. And Julia ran with the idea that I had, which is great. You know, I do medical legal work, and there's been a lot of training by SAMLA, the South African Medical Legal Association. And one of the things that's come up, and just recently on the traumatic brain injuries, what Dr. Herman Eardeling has stated very clearly, when you get a patient who comes in to casualty from the traumatic accident scene, etc., the doctor's job is to fix all the problems that have occurred, and very little attention is paid to the brain. And problems come up years later when it becomes a medical legal issue and you have to write a medical legal report. When you get to the doctor's reports and the hospital records, there is such little information. And this is what I feel strongly about. Right from the time the admin clerk is taking information, that clerk needs to be trained to take all kinds of numbers. So often when we have to make calls, there sometimes isn't even an alternate number. Now you've got a patient that might be in dire straits and there's nobody you can contact. And just today, for example, we had the patient, Julia, that you had referred, who the child's father who died a month ago, when the mother was in hospital with us and her husband was actually dying at that moment, and she didn't take the call, only to get home and discover family members coming there to say what's happened. So nobody actually knew, and now she's struggling with all sorts of issues related to grief for not having answered that phone call and for no other family member's telephone number over there, and they could have possibly visited the patient or done some such thing. So it's tragic that this elderly man had no family member that was informed. So it's a matter of administration. It's a matter of taking down information that is vital. And, you know, I coined a term long ago, treat every case as if it's a potentially forensic case, so that later on, you're going to have all your records on track. And the doctors were criticized severely by the neurosurgeon for not putting in relevant information. He gave thumbs up to the OTs, the psychologists, the speech therapists who record in detail what the patient's status is. And from there, you can actually make up what the person's post-traumatic amnesia was, etc., etc. So the point I'm making is that it becomes everyone's responsibility, despite their busyness, to take down vital information.
Maybe then the actual hospital needs to change the forms and make them more comprehensive, make them far more comprehensive.
They should, because this is important information. Imagine your father is dead and you're not informed. I mean, that's such a shock. That's so tragic that a little telephone number, and the admin clerk or the phone must insist on such details, biographical details. We have a lot of children that come from the home as well. And often they will give us, we might have the number for the home, but we might not have the number for the carer. So whenever the carer brings a child, I make it my business to find out what's the number and whether there are other numbers that we can contact them on. So it just becomes a way of working eventually.
No, absolutely. And I think that's very, very important to even start the process. Diane, welcome. I see your hand is up. If I can just ask you to unmute. Thank you.
Okay. I think I am. Thanks.
Yes, you're all good to go. Thank you.
Thank you very much for the discussion always. And I'm so sympathetic to all the challenges and really do have an understanding of them. However, my little contribution today, I just feel I want to pay tribute to every single person, professional or otherwise, who is involved in this whole difficult and challenging situation, because I think there's so many people doing such fantastic work, and to have ideal situations in this time of chaos is virtually impossible. And sorry, Tutu, I can only see your name, Tutu. I'm not sure of your surname, so please, with respect.